give us a second. Good afternoon, everyone, again. My name is David Johnson, and we're back. So happy spring to everyone. After a couple of months of taking off because of federal holidays, we are back to our conversation around the Telehealth Learning Collaborative and talking about telemedicine all across the state. So we have a number of people on the line today. Something like 87 people registered. So thankful for all of your participation. We have a pretty jam-packed schedule, and I'm going to kind of kick it right off, get us started. I'm going to turn things over to Wade Abbott, and I'm not sure if his folks are on the line or not. Wade, I'm going to unmute your line. But we wanted to bring you on first to introduce some folks from the Senate to talk about what's happening with some legislative efforts.
Thank you. I'm not sure if they're on the line or not. They may have had other issues come up. It's a busy day here, of course. At the,
yeah. So it was
seeing them on the list.
Teresa was one, right? I was looking for her name, but I don't.
Teresa and Melissa.
Okay. I don't see either one on there, Wade. So, Wade, why don't you just introduce yourself and at least talk about what we were going to do there?
Okay.
Okay.
And I don't know if perchance maybe they're listening in, but just didn't get everything connected quite right. But if they are there, they may be listening in. My name is Wade Abbott. I'm the Director of Communications for the Legislative Commission on Rural Resources. I work for Senator Pam Helming. She's a brand new senator to the Senate this year. And I know that legislation related to telehealth and the parity reimbursement has been an issue of importance to folks on the call. So there has been legislation introduced by both Senator Young in the Senate and by Assemblywoman Jenny in the Assembly.
Mm-hmm.
And the reason that Melissa and Teresa might be participating in the call. I see
Teresa just came on, so hang on just a second. I got to make sure she enters her PIN, and then we can unmute her line. Teresa, if you can hear Wade and I, we're just hoping that you can enter your audio PIN, and then we can unmute your line. Teresa Rossi, right?
That's correct, yeah. Or it looks like Melissa's online as well.
Is she on too? Let's see. Melissa Keogh. I sent them audio pins, So this is the way these go sometimes, folks, with all these people on the line. There's over 50 people on the call right now. So,
well, while we wait, I think
ahead,
Melissa and Teresa both work in Senator Young's office. And since Senator Young carries the legislation, that's why I thought it was most appropriate for them to give just a brief update on the legislation. I don't know that there will be much to that update, but see if we can get them on.
Yeah. So Teresa and Melissa, if you could enter your audio pin, I can unmute your line. But I can't do that before you do. Maybe they're hiding deliberately, Wade. What do you think?
They may be real busy.
So this is budget season.
If you want, I can give you the best update that I have. I don't know that they would have more information. And then if anybody has any questions.
Yeah, why don't you go ahead and do that, Wade?
Well, for the Senate bill has been introduced, sponsored by Senator Young and co-sponsored by Senator Ritchie, and it has been referred to the Health Committee. And in the Assembly, that bill has been referred to the Insurance Committee. So right now in the Senate and Assembly, most of the work is really focused on the budget. So that's kind of the primary focus right now. And once we get through that process, which hopefully is over the next couple of weeks, and get a budget passed, then you may see more movement on other legislation as well. And I don't want to speak too much for these particular bills since I don't work for who's sponsoring them.
Can you just give us the numbers, Wade?
I can. Yep. The Senate bill is Senate Bill 834.
Okay.
S834, and in the Assembly it's A1421.
All right.
That's about all that I have. I don't know if anybody else has questions on that.
It looks like Melissa. Melissa, I finally got your audio pin. I think you're unmuted now.
Oh, great.
Hi, Melissa.
Hi, how are you?
Good. Thanks for joining today.
I have Teresa Rossi here as well from Senator Young's office.
We're both at the same site on the same.
Okay, great. Thank you. So, Wade, you might have heard Wade just give us kind of a brief overview. Do you have anything to add to that or other thoughts?
We actually did not hear Wade's overview. I apologize.
Do you want to summarize quick, Wade?
I just mentioned that the bills had been introduced by both the Assemblywoman Jenny in the Assembly, and by, of course, Senator Young. Gave the bill numbers, referenced where they were. That the Senate bill is referred to the Health Committee, and the Assembly bill was referred to Insurance Committee, and that right now the focus is for the legislature is primarily on the budget.
Correct. Yes.
So Wade did a really good job of summarizing that then. Anything to add, folks? Melissa? Teresa?
I mean, I think Wade is correct in that, you know, a lot of the bills that are passed later in the year are subsequent to budget. So that we'll be working on this bill to flush out any concerns that are out there, you know, actually as soon as the budget is passed.
Do you want to, Melissa or Teresa, do you want to talk about what the bill that's proposed, both in the Assembly and the Senate, what are they trying to do? What are they saying?
Well, you know, we're basically providing. I'm assuming you're talking because we know, you know, we have a number of telehealth bills.
Okay.
But the one that is the 834, I'm assuming.
Mm-hmm.
Okay. So we are just trying to make sure that telehealth services operators in more rural areas of the state where there are provider shortages are not going to be disincentivized at all.
Right. So it's as I understand it, we're trying to get at the full payment parity there, right? Is that correct, Melissa? Did I?
Yes.
Okay, perfect. Let's see if there's any other questions here that I can address. I think that looks like that does it. So again, thank you for joining us, Melissa, Teresa, Wade. Thank you for the intro. And if there's any other questions
David?
for them, yeah.
This is Katie. Hi, everyone. I'm seeing a few unanswered questions from Iris Berman and Joel Richmond.
Yeah, so it looks like, Joel, we addressed your question, the question of what the bill does.
Okay, gotcha.
And Dottie, I think Dottie also asked that similar question. So the bill we're talking about in particular addresses the parity legislation. So New York State's law was coverage parity, but not payment parity, and that this new bill is going after that. Iris, you're muted until you have a comment, so if you've got something, just raise your hand, or you can enter a question in the question box or in the chat box. Okay? So thanks again, everyone. I'm going to move on now. In our agenda, we have time for the Department of Health. And Rayanne, unfortunately, couldn't join us today. And I don't see that Joan is on the line. But if you, if anybody from the Department of Health is on the line and would like to give us an update, we're anxious to hear from you. Just look at this.
David, this is Katie again. I know that
Yep.
Rayanne had sent an email earlier indicating that the only update she really had was that they were hoping to have Project Echo approved and ready for release in the near future, and that details would come in the coming weeks about that. That was all she had.
Yep. Thanks, Katie. Yeah, so that'll be exciting. If they get that put out there, we'll see some kind of incentive for Project Echo. That should be exciting. The other thing I'll just mention, many of you who have participated in the Telehealth Learning Collaborative have seen some of the regulations that the Department of Health is working on. You'll also find those on our website. It's telehealthny.org. But the version we have on our website is version 22. And it is my understanding that they're now at version 25. And there's a question, I think, from Will Irwin here about progress on reimbursement for physicians working from home. Now, this is one of the questions that we really wanted to ask from Rayanne or Joan today, but we were, it's our understanding that in version 25, it does allow Medicaid reimbursement for physicians to work from home. We're not certain about that at this point, but that's what version 25 looks like. So we'll continue to seek clarification on that and let you know as soon as we can. Any other questions? I know Judy Moore has some questions for them around, I think, Judy, here, I'll just unmute your line. If you want to, your question, Judy, was around the University of Vermont and the whole Article 28 ruling, right?
Right. But before can you hear me?
Yeah, yep,
Okay.
We can hear you, Judy.
I'm kind of going back to that version 25 that you
Yeah.
just mentioned. I'm wondering if, oh, I'm getting a wicked echo here. When
Sorry about that, Judy.
if Medicaid does allow physicians to work from home, do you think it's just New York physicians in New York homes?
Yeah.
That'll just come along with all the other questions, yeah.
Yeah, that's a good question. We'll have to find out. I'm not even certain, Judy, that that ability to work from home is in version 25 or where it will end up.
Right.
That's just kind of what we've heard.
Yeah. So yeah, and I think the questions that we have at the hospital here is I only have access to version 22 at this point, but that concern about the distant site needing to be that the physician would need to be like in an Article 28 facility,
right.
which we assume is that's a strictly New York title.
Just
so
New
we're
York.
wondering if physicians from out of state will be able to practice. And well, will they be reimbursed? But also, even if they weren't reimbursed, would they be even legally able to practice with, like if they had a New York license? So there's, I guess, a couple different questions.
Yeah. So at least, to answer what we know there, at least in our understanding, the law says that you can practice. Whether you get reimbursed is the question. So I think at least that part we are fairly confident about.
Oh, okay. So if I was a vendor from, or a direct to consumer vendor in Vermont, I could be patients if they paid in cash.
Paid directly.
It would not be illegal as long as I had a license. Okay.
That's right. Yep.
Well, that's good to know.
Thanks,
David.
Thanks, Judy. Got another hand raised here from Joey Marie Horton. So, Joey?
Hi, guys. How are you?
Good. Thanks for joining, Joey.
So, we were just talking about with the physician's home. I think I had sent to David, but I did get an email from Joan indicating, which I assume to be in the most updated version, indicating that the person could be in any location which a qualified practitioner can conduct a HIPAA-compliant telemedicine visit.
Yep.
So, I mean, and I asked that
thanks
in
for
current state, given, I gave her a sample of a project that we were looking at, and that was the response. So, to me, that is the physician's home.
So I didn't want to give you away, but thanks for offering. Yeah, that's kind of the chain of reference that we're going with at this point. We think that that's version 25 and what it allows for, which is great news. We just haven't heard it confirmed from either Rayanne or Joan. So now I assume the email came from Joan, so I assume that we're okay. But that should be great news, for folks who are, that has been a big concern for us on this call. So thanks for sharing.
You're welcome.
Let's see if there's any other, Katie, do you see any other questions for me that I've missed?
I actually can't see questions coming in. I just see question marks next to individuals' names.
Okay. I think I've answered everything here. Oh, Dr. Richmond, the question about version 25. Version 25 is of the Department of Health regulations, which relate to Medicaid. So that's what we're trying to determine, Medicaid reimbursement. I think that's everything. So if you have any other questions about that, please forward them on to me, and I'm going to try to schedule some time with Rayanne and Joan to address those questions that we've already identified. Let's see. I know that Aimee is on the line, and so Aimee, you're unmuted. Do you want to give us any kind of update or thoughts from OMH?
Sure. Thanks, David. We've also been struggling with the same question about the physician being in their home to provide services. We've had a lot of questions around that, a lot of people hoping that that's something we'll see in the near future. We're exploring it. more with the possibility of working with some of the companies that exist out there that provide psychiatrists.
Yep.
And maybe looking at if they're part of an accreditation process, we might be willing to look at that a little closer. But to answer, I can't answer the question about the DOH piece, but for OMH, they would need to be located in New York State.
In New York State, right.
Yeah, yep, licensed, credentialed, and sitting in their home in New York State, at least at this point is what we've talked about.
Yep. Yeah, so on the accreditation piece, do you think, Aimee, like something like the ATA's accreditation would be the type of thing you're looking for?
Yeah, that's what we've started to explore. We've had one conversation with the ATA, a couple of conversations with URAC, both of which are working on an accreditation process. And we just want to see what that looks like, because a lot of it has to do with telehealth, not necessarily telepsychiatry. So we need to make sure that there's a strong focus on that for the OMH programs.
I'm just looking here. Oh, so to that point, Dr. Averill George is thanking Jesus for version 25 of the DOH regulation. So I'm with you. Appreciate that. Let's see some other questions. Let me unmute Dr. Richmond for a second. Joel, I'm going to just have you ask your question because it's directly related to Aimee's purview, I think.
Right. Can you hear me?
Yep, we can hear you.
Yep.
I was just wondering what the reasoning was behind the restriction in not being able to provide telehealth services to patients in their home.
I guess maybe that's two different questions. So we're not at all exploring the patient sitting in their home. They still need to be located in an Article 31 site, but we are exploring the prescriber providing from their home or a private office, which we've up to this point not approved.
Yeah,
we don't feel comfortable. Oh, sorry, go ahead.
I was just wondering what the reason is for not allowing the patients to be seen in their home. The whole idea is, with telehealth, is to give access to people who can't readily have services. Some of these people are homebound. What was the thinking that said no, you can't provide services to someone who's in their home?
I think there's a couple of ways of looking at that. One is that the idea of people, and again, I understand there are some people that are homebound, but the idea of getting people out of their home, around others, into that clinic setting, there's a lot of benefit that comes from that, and we didn't just want it to be an option for everybody to just be sitting at home. The second part is that there's a lot of safety reasons that come with that. What if there's suicidal ideation? What if there's risk? How do we assess that setting for privacy? All of those things come with that, and we're just not comfortable at this point with moving forward in that direction.
Thank you.
Thanks, Dr. Richmond. Any other questions for Aimee? Let's see. There's a question here from Maria. Let me just see. Maria, can you just kind of state your question so I don't have to read it quick?
No, I agree with Joel in that having the patient remote is more important for us as opposed to the provider. At Planned Parenthood, we have extensive national experience with patients being remotely located and moving forward with providing care. It's imperative for us to be able to reach patients who cannot travel into an office. So we really would like to see the limits pushed of the patient being remotely accessible more so than the provider, because we aren't doing telepsychiatry. We're doing services such as, contraceptive management and counseling. So I think this is really something important that's been widely tested in our agency out west in many states, and it works very well. There really isn't a problem or concern with the patient being in their home.
Yeah. So,
And
Maria,
I think that's. Oh.
Go ahead,
I was
Aimee.
say, I think that is a good point, Maria, and I think we might be talking about two different types of individuals in terms of the service that they're receiving. When we think of individuals that are in an Article 31 setting, we may see individuals with some more severe symptoms, and that piece about suicidality and psychosis and all of those things that are a lot harder to monitor for in the home, but maybe some of the services that you're talking about could be something that's more appropriate. The other piece with that, though, too, is at this point, we only approve prescribers. We don't approve for counseling or therapists to provide any type of telemental health at this point.
Right. Well, I mean, our prescribers would like to use it for things other than mental health, but we also do some lower level prescription therapy. Actually, Joel's group is co-located in our offices, and we do use telemedicine for some of those site-to-site visits.
Okay.
But I think there would be a way to unrestrict access and still make it safe.
Yep. So, just to clarify for everyone, and we've kind of encountered this confusion at different times. So what Aimee is talking about is really the regulations for OMH licensed clinics, and it doesn't apply across the board to every setting. So, so OMH is kind of governing what happens in OMH and their clinics, but that doesn't necessarily restrict or confine what you might be doing, Maria, or Dr. Richmond, outside of a OMH clinic. Do I have that right, Aimee?
Yes, thank you, David. I think that's a really good point to make, is that our regulations only apply to Article 31 licensed agencies, because we include inpatient now, CPAP, partial hospitalization in addition to clinics. But if it's not something that's regulated by Article 31, we don't have any say over that.
Does that answer your question, Maria? I think maybe I just lost her. Maria, are you still there? Okay. Let's see. I don't see any other questions about that at this point, Aimee, so thanks for that update. Let me see if I can move on to, I don't know that Mariah is on the line. I don't see her, so we might not have an update from Excellus today. But, I just wanted to kind of mention that certainly Excellus in our region is really ramping up their direct-to-consumer model. Their expectation is huge in terms of patient encounters and what they're thinking is going to happen there. So that's pretty exciting, interesting. I know that we've had several conversations in the Jefferson, Lewis, and St. Lawrence counties about what we might like to see direct-to-consumer models look like, seeing them both as somewhat of a threat, but also as a great opportunity. So more to come on that. I think we should, continue to talk about it. Let's see. Okay, let's hop over to Katie. Katie, you have the line, and give us an update on what's happening over there in the Adirondack region.
Sure. So hello, everybody. I'm not going to share my screen just because I didn't get a conference room today, but to give you a brief update on telehealth progress in the Adirondacks and Glens Falls region, reason being that most of you on the line I'm noticing were former members of the Telehealth User Collaborative. As you know, through emails over the last several months, we've decided to join those forces with the Learning Collaborative, so I want to make sure that this region is represented as well. That being said, I've been in this role since late November, and with David's help, I was able to get the first successful telepsychiatry project up and running up in Elizabethtown with Essex County Mental Health. So that is now up and running and growing. And we have a number of projects that are coming down the pipeline. We're working with Glens Falls Hospital. We're working with the Warren Washington Association of Mental Health. We're working with numerous public health departments as well as government organizations looking into school-based telepsychiatry. So there's a lot coming down the pipeline that I'm hopeful over the next several months we'll have more updates for you. We're hopeful that through the work of the Learning Collaborative that we can ease the barriers of access for telemedicine, as the Adirondacks and Glens Falls have been characteristically a little slow to adopt telemedicine compared to other parts of the state and the country. So I've been working diligently to try and change that, and we're seeing some real progress. I'm very fortunate that Caitlin Huntington, who was in this role prior to me, planted a lot of seeds. So it made it easy for me to kind of pick up and really help those seeds to grow. So that being said, we're just going to continue chugging away, getting more and more organizations on board. It seems that telehealth is becoming more and more widely adopted and thought about in this area, and that's really exciting. So,
right on. Thanks, Katie. And speaking of progress in the Adirondack region, we have Dr. Gellman on the line. And yes. Dr. Gellman, we wanted to kind of give you the floor. I'm making you the presenter now. And love to hear about what's happening with the Fulton County Telehealth Pilot and countywide initiative. So, we can see your screen. Dr. Gellman? Can't hear you, though. Oh, I can see you now. You might have to dial in. We can't hear you. We can see your screen, Dr. Gellman, and we can see you. Let's see. Do you have the phone number, Dr. Gellman? Shake your head, yes or no. I don't know that she can hear me. Oh, she's saying yes. Okay. Do you have the phone number, Dr. Gellman? Did you try to dial in? Okay. Did you enter an audio pin? Okay. That didn't seem to work. Let me try something else. Dr. Gellman, could you kind of hang up the phone and then try dialing in again? Okay. See, we're so good with technology. We are the Telehealth Learning Collaborative. I think we've got you, Dr. Gellman. We can hear you now.
Unmuted me.
There we go. Yep.
Hello, good afternoon. Can you see my screen?
We can. Thanks for sharing.
Great. Okay, let me just...
Oh, it's perfect.
Okay. And you can see me and hear me?
Yes, we can.
Thank you. Today, I would like to discuss the telehealth initiatives in Fulton County, New York. This is a presentation that was similar to the one I gave at both NYSHO for my Fulton County Human Services Committee at the Board of Supervisors for Fulton County. And it's somewhat reminiscent of the TED Talk that I have recently given. Telehealth, I think we can generally, pretty much we've seen similar slides. Telehealth being the overall encompassing, sort of all-encompassing definition for any remote access to care services that include telemetry and telemedicine components. I think we all pretty much at this point are aware of the differences between telehealth and the telemedicine, which would be a component of telehealth. The New York State definition pretty much defines telemedicine store and forward remote patient monitoring and excludes audio only, fax only, and email only transmissions. We've discussed somewhat in detail the telemedicine use of synchronous two-way electronic audio-visual communications that deliver clinical healthcare services, and the hub-spoke or the distance site originating site, with the distance site being the location of the telehealth provider and originating site being the location of the patient. Store and forward technology, the asynchronous electronic transmission of patient's information, and that would be limited to ophthalmology, dermatology, other disciplines as determined by the commissioner. Remote patient monitoring is more of the telemetry component of telehealth. And the Telehealth Peri Law, which we've also discussed in detail, New York becoming the 22nd state to pass telehealth parity legislation for practice, as we all know. And that law came into effect on January 1st of 2016. Let's see. For Medicaid reimbursement, and I'll touch upon that a little bit later, but I love the fact that the conversation that preceded this kind of touched upon the general reimbursement status, because my presentation, I think, is the anchor for the fact that for public health purposes, we're not really considering the reimbursement component because, as those of you who may be in public health are aware of, we don't really get reimbursed for much to begin with, and if we're really tasked with population-based health and improving access to care, for us, reimbursement at this point is not as much of a consideration while we're building the framework for access to care or remote access to care, as it may be. So for the public health and population health purposes, being a health department, a local health department, those two issues remain separate for us, where actual practice and provision of remote access to care services being telehealth still remains sort of separate from the reimbursement component, which goes part and parcel with the service provision and more of the telemedicine component of telehealth. Fulton County, New York is a rural area with restricted access to care, given our limited provider panel, remote location, low overall population density, resulting in poor health outcomes. Now, Fulton County, New York has a population that vacillates at around 55,000 people, with 15.9% being 65 and over and 21.2% being 17 and younger. Our education and poverty rates, we are greatly affected by poverty, disproportionately so. The level of educational attainment remains very low, well, higher education attainment. We have 7 school districts, 85.7% of residents 25 years or older with high school diplomas, while only 15.7% obtain a bachelor's degree or higher level of education. 16.2% remain under the federal poverty level as compared to 11.8% in the rest of upstate New York and 15.6% New York statewide. 18.6% are single-parent households as compared to 16.6% in upstate New York and 19.8% New York statewide. 21.9% received Medicaid, and that number has continued to climb, where we are closer to about 24-25% now, with 47.6% of children being eligible for free or reduced lunches. Our healthcare landscape happens to be 155 registered physicians with as compared to 215 in the rest of the Adirondack Rural Health Network region, and 285 on average New York statewide. We have 92 primary care physicians of those registered physicians noted. We have 1 hospital, 1 urgent care clinic, 13 primary care clinics, 19 registered physician assistants, 20 nurse practitioners, and our health outcomes pretty much reflect that healthcare landscape, where our overall health rankings, and keep in mind this is out of 62 counties, being I believe 5 are for New York City alone, so you do the math there. Overall health 47, length of life 48, quality of life 49, health factors 56, health behaviors 50, clinical care 53, social and economic 58, and our physical environment is 32. We have a pretty nice landscape here and 44 lakes. As you can see with clinical care, socioeconomic reasons, and the health behaviors and overall health has actually, we went up on the chart a little bit because it was slightly lower when I came on board. Leading causes of death are heart disease, cancer, chronic lower respiratory disease, stroke, unintentional injury, in that order. Premature deaths are mainly due to cancer, heart disease, chronic lower respiratory disease, unintentional injury, mainly due to substance abuse or driving while intoxicated or such, and the final being stroke. Our public health priorities. Fulton County, New York is considered to be a health professional shortage area for primary care, mental health, and dental care. For obesity rates, 30.9% of adults are obese as compared to 27% of their upstate New York counterparts. 19.5% of public school children are obese as compared to 16.7% in the rest of upstate New York. Our smoking rates have continued to climb from about 24%, I believe, 3 years ago to the 29% that you see now, as compared to 17.3% of the rest of upstate New York, and actually continuing to climb, unfortunately. So our cancer are ovarian, colorectal, followed by prostate. Telehealth initiatives may provide a viable solution to the increased need for remote access to care here. Telehealth being the, as I mentioned, overarching concept that includes telemedicine and telemetry components. The benefits of telehealth include evidence-based cost and time effectiveness, again, in the realm of public health, and may have a major impact on overall health outcomes. The telehealth Fulton County pilot, the pilot that we have started is actually a pilot that will hopefully take off within the next month. We have gathered a number of stakeholders, both locally and regionally. We have utilized district engagement funding, and we are lucky enough to be part of the North Country District with AHI. We've utilized both year 1 and year 2 engagement funds to start the pilot, and the pilot will entail health stations at our local community college, the public health department here, the Office for the Aging and Youth, and with 2 stations, 1 in each of the hospitals that serve the area, one being Nathan Latour Hospital and the other one being St. Mary's. Now, the Fulton County pilot is geared to evaluate patient-centered outcomes with regard to remote access to care and assess utilization rates and the value of such access, and that would be more to measure the metrics for our county-wide telehealth initiative, which I will discuss in a minute. As I've mentioned, our community stakeholders, and with the approval of the Fulton County Board of Supervisors, we've utilized the funding to set up the 3 main health stations that will connect to our local emergency departments of the 2 main hospitals here. We will utilize an encrypted HIPAA and FERPA compliant platform video to connect our county residents in real time, not in store and forward to the healthcare providers here, or pretty much any provider of their choice. The server will be housed with the Fulton County IT department for neutrality. And this is a very interesting statistic. We recently had a survey actually for one of our apps that the Emergency Preparedness Office wanted to start up, which we're actually in the process of working on right now. And that survey has demonstrated that approximately 70 to 75% of Fulton County residents have a smartphone. And that's an astonishing statistic right there, because regardless of the socio-demographics and the statistics that I cited earlier, about 70 to 75% of our residents already have a smartphone. And the larger percentage, of course, utilize other technologies such as laptops, tablets, and personal computers. And if we just pause here for a moment and contemplate what that can mean for the applications of public health, not right now, one second, for the applications of public health, we can truly leverage existing technology. So I think that's an important fact to mention, because if it can work in Fulton County, I think it can pretty much work anywhere, especially for the purposes of population health or public health initiatives. Now, the countywide initiative, this is what we're working towards, hopefully. Ideally, Fulton County residents will be able to utilize their own smart personal devices in their homes and throughout the community. And I understand that completely contradicts what was just mentioned previously, but please keep in mind that the prior discussion truly focused and centered around reimbursement, not the actual provision of care. And I think it was highlighted, this is something that both David and a number of the participants mentioned. There is a tremendous distinction between the actual provision of services, which is allowable by the Parity Act, and the reimbursement for such services. So for the purposes of this particular presentation, we will keep those completely separate. Health stations will be available as a supplement when alternate means of access are not feasible. That way, all of our residents can take advantage of the technology that's available. And of course, this is my public health utopia, and I wasn't kidding when I mentioned that this was in my office, because I actually do have this framed in my office, just for the record. This is a public health utopia. This is a slide that was created by Clem Biesold, who's the chair and futurist at the Institute for Alternative Futures. And this was at our Public Health Leadership Summit. And this was a vision, Public Health Vision 2030 that was created specifically for NICHO in his talk. And as you see, this has a true vision of the public health utopia that at least I would want to see, with the value shift to positive public health movement, communities promoting population health, widespread health consciousness, value shift to equity, self-care, our local political leaders promoting health and public health initiatives, of course the telemedicine component, which is my personal favorite there, community pride, engaged public, so really taking accountability for your own health there. These are a couple of the references, and I will take questions if you have them.
All right. Let's see. Any questions for Dr. Gellman? By the way, I'll just mention, kind of waiting for some questions. Dr. Gellman is kind of world famous now. So if you, well, it's on the World Wide Web. So come on. So you can check her out on YouTube. I think she did a brilliant TED Talk on this same presentation. But we're excited about what's happening over there in Fulton County. So it should be really, really exciting. Dr. Gellman, in particular, I'm really excited about the community college and how that's going to play out as a presenting site. Can you just talk a little bit more about the kind of the situation at the community college?
Yes. So the way this came about was actually Of course, with me moving here, and there was the whole story in TED Talks, and you would have to stay tuned. I'll leave a cliffhanger there, so you actually tune in. It's a 15-minute talk. But the tremendous issue upstate versus downstate, and I happen to be from New York City, was the difference between seeing a doctor at any time that you needed to, meaning Saturdays, Sundays, after school, after work. You could pretty much dial your local office, whether it's the pediatrician or you're a primary care provider, and you're, for the most part, in, and you could see a doctor. As soon as I was appointed here and I came up here, all of a sudden I've noticed staff bringing forms for me to sign because they had to go see a doctor. And that was a preposterous idea when I first came on board, because what do you mean see a doctor on your own time? Well, for the most part, the clinics, at least here, hello? Can you hear me?
Yep, you're still with us.
Okay, just checking.
Yep.
For the most part, the doctor's offices here in Fulton County, New York at least, work pretty much between the hours of 8 to 4, Monday through Friday. And for the most part, most of the offices from 12 to 1 take a lunch break. And I also happen to take a lunch break at from 12 to 1. And I have 3 kids. And getting one of them to a pediatrician's office was completely impossible, because I couldn't even make the appointment, let alone actually take time off and actually get them to the doctor. It's a whole ordeal. So for us here, access is not just the conversation of having a provider panel. It's actual access in terms of calling, scheduling the appointment, showing up for the appointment, because having a tremendous amount of people working, but being the working poor, so to say, where a lot of them may be uninsured, underinsured, they're not really using their sick days to go and see a doctor, especially for preventative care. You're lucky if they're seeing a doctor for a chronic care condition or for an acute condition in real time and not presenting to the ED. So the story with the Fulton Montgomery Community College is such that being a community college of about 24 to 2,600 enrolled students, having a dorm on campus, they do not have health services. They haven't had health services for the past, I would say, safely 7 to 8 years now. And their protocol includes any student that becomes ill and exhibits any sort of symptoms, automatically either would call or present to the safety officer. And as soon as they, and upon presenting, the safety officer would call 911. And as soon as they would call 911, they would be transported to the ER of one of our 2 hospitals here. So for the most part, it's St. Mary's Hospital, but at times St. Latour Hospital. So you could see how right there alone, we can pretty much impact a lot of the goals that even districts set for us in terms of ED visits, reducing ED visits, and potential rehospitalizations. Also, the considerations, we have many large employers that, given the opportunity to take over a closet, as I'd like to say, I was actually quoted for saying this, that I'm taking over closets all across the county. Given the option of taking over a closet at the larger distribution centers or one of the larger employers, an employee is more likely to use that 15-minute, one of the 2 15-minute breaks that they have, hopefully not to go smoke an extra time, but actually to present to one of these closets, sit down at a health station, and actually connect into a provider for a slew of, it could be a completely different set of services. It may be prevention services, it may be counseling services, it may be public health services, I mean, you name it. It could be a slew of different services that we may offer. So again, for the purposes of public health, it made a lot of sense. So we've discussed it with the 2 local hospitals. And clearly, again, I'll reiterate, for the purposes of reimbursement, that this doesn't work too well, because this is in the realm of quintessential population health. This is population health and increased access. But if we leave the conversation of reimbursement for a minute, and I'm not sure if what the rates would be or what they are currently, whether they're $12, $20, $30, I'm not really sure what the rates are. But if we leave that discussion altogether, and we discussed it sheerly in terms of statistics, and the statistics and demographics of it dictate that there is a segment of the population we are just not reaching. And by we, I mean collectively as a healthcare community, whether you're a hospital, whether you're a public health department, whether in any sort of aspect of care provision, there is a segment of a population, and I want to say male to 27 to 47-year-old, but I won't say that because we don't want to single out any segment of the population. But there is a segment of the population that we're notoriously not reaching, and they're mostly working, younger individuals that they may not be at that threshold of chronic disease just yet, but they still present in an acute care setting to the hospital, and that's the only setting that we can pretty much see them in. They are the segment of the population that we may reach with an initiative like this, where they're able to present either at the community college, or they're able to present at one of these health stations, or even connect in from their own home, which that's the direction we're hopefully going towards, because if we're not preoccupied with the reimbursement aspect, we're actually able to leverage existing technology, being their cell phones or laptops or tablets, and having them connect in for whatever reason before them actually presenting to the ED. So, or before them actually presenting continuously for a chronic condition that we may potentially have avoided because they presented earlier. And that's your smoker, or that's the person that happens to imbibe a little too much, you know, when they shouldn't. So for our preventative initiatives, and I'll be selfish here for a moment, for public health, this makes a lot of sense. And the way we had the discussion with the hospitals is, and the hospitals were actually thrilled about it. We have two amazing hospitals here, both Nathan Latour being sort of our main hospital in Fulton County, and St. Mary's Hospital. They were both on board pretty much right from the very beginning, because first of all, this is a trajectory that we're taking on, because we are slowly in every other aspect of life moving towards the technology, and the technological integration is seen across the board. But more importantly, improving that access means that that demographic, that subset of the population that we're not reaching, are actually may connect into one of these providers, and hopefully if they receive some sort of advice or service that they may deem necessary in the future, they will present to that system later on. So, I mean, essentially, that's really the long-term trajectory. And this is the subset of the population, again, that we're not reaching by billboards and newspaper advertisements or the radio segments that we're doing, both us and the hospitals. So it makes a lot of sense. And what we've done thus far is we've identified, as I mentioned, closets at the Fulton Montgomery Community College, at the Public Health Department here, and at the Office for the Aging and Youth. And those closets are being outfitted right now as we speak, and we're actually setting up the final meeting for our business agreement and all of the paperwork at some point this month.
Dr. Gellman? Sorry,
yes.
We do have a question here from David Colarusso. David, I think I've unmuted your line now.
Oh, can you hear me?
Yep, we can.
Oh, good. Go ahead.
Oh, we just lost you for a second. Try again.
Can you hear me now?
Yes, we can.
Sounds like a Verizon commercial now, doesn't it?
It does. Can you hear me now? We can hear you.
Okay. Hello, Dr. Gellman. It's nice to meet you.
Hello.
I come from the Department of Veterans Affairs, and I'm wondering about, in our program, the idea was to keep the veteran out of the hospital because it's such an expensive proposition when the veteran is admitted. And in our case, my program allows us to deliver both medical and psychiatric care at the same time in one visit. And so what we developed was, back at the James Haley VA Hospital in Tampa, the program was set up so that my nurse practitioner, myself, I'm a geriatric nurse clinician, and my doc and our therapy dog would see veterans all day long. And the idea was that we could do everything that they might need in a home visit, including admitting them if we needed to. In the state of Florida, there's a law called the Baker Act, which allows anyone that's a professional licensed to commit someone if there's any hint that there might be a danger to self and others. And so occasionally we would do that. But by and large, it worked because the veteran wanted us to be there. They wanted us to come to see them. And it gave them the independence that they otherwise would not have had. And so I'm wondering how this might work in this state, because I know you're up against some HIPAA regulations and privacy issues and things like that, but the VA doesn't have to deal with as much. I mean, we have to, but not quite in the same way. What do you think about that?
Well, as I mentioned, the HIPAA and the FERPA compliance is in place because we're not using store and forward. The servers here at Public Health, and this is an encrypted HIPAA-compliant platform. It's not as if we're using Skype. And more importantly, if we're not preoccupied with the reimbursement aspects and meeting the caveats in place for reimbursement, that's precisely where we're trying to head, in the direction of full integration. And that's why we're moving towards the county-wide initiative. Because we have had conversations with almost every single entity, and I do say this with full understanding of what I'm saying. We've had a conversation with the law enforcement community. We've had a conversation with our sheriff's department, with mental health services, with Planned Parenthood, family counseling centers, prevention services, HFM, BOCES, all the school superintendents. Ideally, we are trying to I think when district evoked the concept of breaking down silos, it was breaking down silos within the Department of Health and health-related services. We're actually breaking down the silos and the barriers between different sources of funding, different organizations, and functioning within the lines of the county, where we're actually meeting, we're convening meetings between all stakeholders. This way it's all inclusive. And the beauty of this particular initiative is it is preoccupied with public health and access and population health, where all of these different aspects have applications for a telehealth station. For instance, school nurses integrating it for what they're doing, because we happen to not have a dentist who accepts Medicaid in the county. So for children's dentition, you can imagine what the repercussions are there. So if we can include that component for the telehealth stations that we're including in the schools. For the Sheriff's Department, obviously mental health services and the provision of counseling and care services within that system is also extremely costly, especially for small rural county. Sometimes the bills run upwards of $40,000, $50,000 for one person. It's a lot. It's a hefty sum to pay. So if we can integrate the telehealth component, potentially not even for the initial visits or consultations, but maybe for subsequent counseling sessions where we don't need transport one way or the other with the provider coming in or the person being transported. We're applying this out. As a matter of fact, we just spoke with a family counseling center director here because they have their own telehealth program. Instead of having separate sporadic initiatives within Fulton County where the counseling centers are doing one thing, Planned Parenthood is doing something else, OSA is doing their own initiative, mental health has their own. We are actually pooling our resources where if mental health, let's say, for instance, right now is seeking funding, federal funding for their telehealth initiative, we're still integrating their initiative into this overall county-wide initiative because it's not really the glory of it. It's really, truly integration. So I think that's the important part right now. To make sure that we have, and by the same token, the Veterans Department, they're very excited about this because they're thinking of the repercussions of and the ramifications of including the Veterans Department here, because if they're seeking services with the Department of Veterans Affairs, why not include them in an initiative that's countywide? They happen to be our residents.
Yep, and there's a large number of unserved veterans, and not only in Fulton County, but across the state, that don't get a chance to take advantage of the care or services that might be available. The result of what you just said is a very positive step in the direction that it needs to go.
Hopefully.
The other question I have is, what kind of hardware can you provide to the client in their home? In my case, we provided them with a video phone, and all we did was, as we dialed the number, their phone would light up and our phone in the office would light up, and they could see and hear us in both directions. And in that case, we could do a lot of the kind of counseling over the phone that we didn't necessarily have to go visit somebody, because that's how they felt the best way to deal with what they wanted to get done. We could do their medicines for them, get their appointments set up for them, all of those kinds of sort of nitty-gritty things that many times the veteran either forgets or chooses to leave undone, and we could do that for them. And I'm wondering, in our case, we had a huge grant that supplied us money to buy these devices, and I'm guessing maybe you don't have that kind of thing, do you?
So essentially that's the difference, and of course there are plenty of publications that show increased compliance, especially with psychiatric counseling services, even something as simple as taking your medication routinely and daily. The compliance rates go through the roof with something like this. I will say this much, because we're integrating different agencies and different agencies have different streams of funding, if they do have that capability of providing veterans or, any other subset of the residents here with certain technologies, by all means we can integrate that. But for the most part, the beauty, again, of this initiative is that it's so low cost. What we've done is we're attempting to leverage the existing technology that the residents already have access to, that they're utilizing on a daily basis, because if they're using their phones, they're more likely to use their phones. If they're shopping on Amazon on their phones or using their Facebook page, they're just as likely to connect into a doctor if they need to ask a question about their newborn or anything else. And they're more likely to contact public health or Veterans Affairs or any other department. So we're attempting to truly take advantage of the technology that exists, but being a rural area, we understand the barriers of connectivity at times, broadband, whatever the issues are. But we are trying to offset that with having these health stations that are going to be set up at either major meeting points like libraries or main street sort of county-owned buildings, or for the most part, the more remote and rural areas such as Ephrata, Stratford, Northville, the areas that are more out there and they're not as connected in, because if people don't have that connectivity or don't have that technology available, they're at least more likely to present to one of these health stations, which will be available at a community center or county building, where, again, we're using a side door to a closet somewhere, but they're able to access this health station. They're much more likely to connect in, because for the most part, even in the most remote regions of our county, a health station happens to be in a county building. There is at least one county building on Main Street, at least one. Even if there are only 3 buildings on Main Street, there's at least one county building.
There's a county building somewhere.
Exactly. So at least we're able to use that health station that may be 5-10 minutes away driving and not 45 minutes away like a hospital. And the issue being, especially Fulton County, I mean, look at the snowstorm we've received. We had over 2 feet of snow. A person, I keep going back to the same 57-year-old male experiencing chest pain in the middle of a snowstorm on a weekend in Ephrata or Stratford. They're not going to listen to their nagging wife, and they're not going to go to the ED. They're not driving 45 minutes in a snowstorm to the emergency room because they have some chest pain. They're going to sleep it off. But instead, now they may have the potential to dial up either from their own home or from one of these health stations that may be 5 minutes away. And if you are in a situation with a stroke or in a situation with an MI, you can tell the patient to actually stay put and not drive, and we'll get to them. So I think there are a lot of applications, both acutely for prevention, for education services, and for everything else. In terms of getting back to what you actually asked me and not segueing into something else.
Oh, this is fine. This is fine.
In terms of actually giving out equipment, because we are very, very tight on the budget end of things, and we're utilizing the district improvement funds, we've only utilized $20,000 for the pilot initiative. To set up the health stations here and actually buy the server and the software and the video platform licensing agreement. And the beauty, again, is it's not a fee for service. It's not paid for use for each call. It's actually a license-based, traffic-based agreement where we're purchasing only the amount of licenses that we need, and you can use them concurrently. So that's the beauty of the video component of it. And we're attempting not to give out the technology, because that's really the point of having these health stations that would offset any issues with utilizing technology or not having it available in your home. If there are other initiatives that are funded through other services like mental health department or veterans departments or anywhere else, by all means, if they could give them technology, of course. I mean, we wouldn't say no to that. But for the most part, we're trying to cap the cost also, because we've estimated the cost for the county-wide health initiative to be at around $80,000.
This is wonderful. I love to hear what you're saying. This is outstanding. This is exactly what we need to do. Thanks for taking the time, Doctor. I really appreciate it.
Thanks, David.
Thank you so much.
Any other questions for Dr. Gellman? it's nice to receive those words of encouragement.
Yes.
So, well, Dr. Gellman, thanks so much. Appreciate how you champion telemedicine everywhere you go. So
yes,
keep up the good work. Thanks again. Appreciate it.
Yes, thank you, Dr. Gellman.
Thank you.
All right, I think we've actually come to the conclusion, at least of our agenda. I'll just kind of leave it open for a minute to see if there's any other questions that are coming in. There's a question.
Sorry, David.
Go ahead.
I forgot to mention that the 3rd Annual North Country Telemedicine Conference, many of you on the line attended last year in November in Lake Placid. We are doing that again. Yes, there's the save the date. It's Thursday, November 2nd in Lake Placid at the Crown Plaza Resort. So please bookmark that on your calendars and look for more information. We are also looking for speakers. So if anybody has any speaker ideas, please send them my way or David's way. I appreciate it.
Thanks for that reminder, Katie.
Yes, I just thought of that.
Yep. There's a question here. Let's see, Carolyn. Carolyn, I'm going to unmute your line. So you have a question here about kind of store and forward and the reimbursement piece on that.
Yeah, I just wanted, this goes back to an earlier part of the conversation. I was just seeking clarity because there was a lot of discussion around with a number of the providers on the phone around, what's easiest for the patient in terms of, not necessarily having to leave their house and using their phones and the technology that's available to them. And so my question was, I was just seeking clarity on this. Like, for example, if a patient is able to use their phone to collect information, collect images, and not necessarily have a face-to-face telehealth event with a provider, but, stores them, sends them for the provider to look at another time, is that when the provider receives those images, does a clinical analysis, is that the way I'm reading the store and forward piece is it seems like there needs to be a clinician-to-clinician transmission.
Correct.
And I'm just trying to seek clarity as to whether the patient direct transmission to a physician would be covered under the store and forward definition as a reimbursable event.
So, Carolyn, it sounds like there are just a couple of applications that DOH is willing to allow for store and forward in terms of reimbursement. So one is dermatology, which is great. The second is ophthalmology. And the third, I can't think of. Katie, what's the third one? Do you know?
Is it retinal related, like diabetic retinopathy? That's
the ophthalmology piece. So I think there's one more, but I can't think of it off the top of my head.
See, I was under the impression that most payers will not reimburse for store and forward, especially coming from a patient's phone.
Yeah, we can follow up on that, Carolyn, and check out our website too, because I think there's some detail on that in a presentation that Rayanne did a while back from DOH.
Okay.
So we'll follow up with you, Carolyn. Thank you. Any other questions or comments here? Let's see. Actually, there's quite a few coming in. And some folks have left here. Yeah, Iris just mentioned here. So Iris, I'm going to unmute your line.
Yeah,
Iris. Yep.
Yeah, can you hear me? Hi.
Yep, we can hear you.
Somebody was asking about retinal imaging. It is reimbursable, has been for a while, and that's one of the, because it's also under population control as also part of the package for managing diabetes. So most things related to that are reimbursable.
And so, Iris, you remember, so dermatology is another one. Isn't there a third one for store and forward? I'm trying to
There were
recall.
three. I can look at my documents when we're done with this call. I do have it. I know there were. You're right. There were at least three in the original. Yep.
So I know the retinal piece and dermatology, but I can't remember the third. Maybe it's teleradiology, but I can't recall.
Yeah, but it was a particular type, I think.
Yeah.
Because that's pretty broad.
Yep.
I'll look for it. It might have been sonogram. Certain
Okay.
types of sonogram.
So Carolyn, we'll get back to you on that one. All right. So I think we've addressed all the questions that have come in so far, and I'm going to call that a wrap for today. Our next Telehealth Learning Collaborative in April falls, I think, on the 17th or something like that. So you'll receive a reminder. 17th. Thanks, Katie. We'll send a reminder out, and at this point, I think we do have a presenter for next time. But if you're interested in preparing some kind of presentation for our group and think that would be valuable, please send me more information, and we'll try to put you on the agenda for an upcoming session. So thanks, everyone. Appreciate your time today. Look forward to seeing you next month. Thanks again.
Yes, thank you, everyone.